Okay, so in this lecture, we're going to talk about the etiology of opioid use disorder. That is to say, we're going to be talking about what are some of the causes of both prescription and non-prescription opioid abuse. We're going to start with prescription opioid abuse. So there's a limited amount of research in this area, unfortunately. And we do have some insights from a qualitative paper by Rigg and Murphy in 2014, basically trying to figure out, what are some of the proximal reasons that people begin abusing or misusing prescription opioids. And so the people that were interviewed for the study mentioned several things in terms of the proximal causes. These are some of the themes that emerged. One of them is self-medication. So basically using opioids, prescription opioids, to self-medicate negative emotions and or physical pain. Another is social influences. Another is having easy access to prescription opioids. And then the last theme that sort of emerged here was for recreational reasons. So I should have mentioned too that paper we were talking about here, basically that sample size is 90 people. And you see here the age range is 18 to 51, includes both men and women. So to be more specific, some of the things that were mentioned in this paper, family history is also an important factor. So 82% of people in the sample reported having a family member that abused drugs or alcohol. I mentioned the self-medication, that is using it as a way to escape negative life events, usually long-standing life events with unpleasant emotional states. A good example here would be childhood abuse. Another point that emerged was, at least for women, that there tended to be a male influence. That is, oftentimes they were introduced to opioids via their interaction with a prescription opioid abusing man. And then finally, this notion of prescribed addiction. That is, the beginning of this is related to being required to take a prescription painkiller as part of a treatment. Now let's transition and talk about non-prescription opioid abuse and addiction. And so why do people transition from prescription opioids to street drugs like heroin? And, the first reason is probably pretty easy to guess. As physicians have become more aware of the problems, and they have basically cut back on their prescriptions, so they're less willing to prescribe. Well, what do people do? Of course, they're going to go look somewhere else for the same kind of an effect, right? So they're going to look for opioids elsewhere on the black market. Turns out heroin is oftentimes cheaper than prescription opioids and relatively easy to get. So another important point here is that heroin also happens to be highly addictive. And there are a variety of reasons why heroin is so addictive that relate to the pharmacology of opioids, which we'll talk about in a minute. So it's even some people even talk about the fact that they began to feel addicted even after the first time they took heroin, and just sort of illustrates how addictive heroin can be. So why are opiates so addictive? This comes down to what makes the drug addictive more generally. And more generally, a short time, like the shorter the time between when you take the drug and when you feel the rewarding effects of the drug, the more addictive it is. So opioids, and in particular heroin, produce euphoric effects almost right away, so people quickly learn to like that drug. The impact of the drug, in this case, impact of heroin and more generally opioids, on the mesolimbic dopamine system in the brain is also an important factor. So exogenous opioids, so when you're taking heroin, but also it's true for prescription opioids, basically they mimic these powerful pain-relieving compounds produced by our own bodies, which are endogenous opiates. And these compounds are produced in times of stress and severe pain. And so because these exogenous opioids like heroin and the synthetic opioids, prescription opioids, produce the same effect, they are very rewarding and very powerful. And then the other factor here that's important for the addictive nature of opioids is the development of tolerance and the avoidance of withdrawal. So once your body becomes used to the drug, right, and there's all these things going on inside your body that your body's trying to adapt to the presence of opioids, and the more it adapts, the more it gets thrown out of whack when you stop using opioids. And so people oftentimes it makes it very difficult to quit because you're trying to avoid the withdrawal that happens when you stop using. So tolerance and withdrawal are also important aspects of the addictive nature of opioids. This is a quick primer on the biology here in the central nervous system. And the figure on the right may seem intimidating, which is no big deal. This is not intended for you to memorize this. This is just basically for those of you who want to dig a little deeper into the details. This figure should be useful. For those of you who just want the 10,000-foot overview, don't worry about the details on the right-hand side. There basically are three families of opioid peptides. We have our beta endorphins, our enkephalins, and our dynorphins that go along with three families of receptors, the mu, the delta, and the kappa. And they are distributed throughout the central nervous system in areas that modulate pain, stress, and reward. And this part over here on the right is just basically showing you those regions that are involved in pain, stress, and reward. And on the left-hand side over here, you'll see the location of opioid synthesizing neurons. On the right-hand side, the location of opioid receptors. And you quickly will note these receptors are in key areas that are not just involved in pain and stress, but also involved in this sort of addiction pathway, like the nucleus accumbens, for example. Anyway, if you want, you can dig more deeply into this, but I will just highlight two key areas in terms of the addictive side, the ventral tegmental area and the nucleus accumbens. So what are the functional consequences of activation of these opioid receptors? And it depends on to some extent, on what we're talking about in terms of which neurons and where they're located. So in many regions, we'll take two, for example, the PAG and the VTA, and these are involved in pain and reward respectively. So the activation of opioid receptors facilitates neurotransmission by inhibiting GABA release from local inhibitory neurons. So basically, the opioids are inhibiting the release of GABA, which then in turn releases other neurons from GABA inhibition. In other words, it's a little bit complicated, but essentially what is happening here is opioids are facilitating neurotransmission, and in particular dopamine neurotransmission, up and down these reward pathways. And it's through an indirect mechanism that involves GABA. That's the important point. Okay, so pharmacology here. This shows you the morphine over here, and again, the opioids we're talking about primarily act on mu opioid receptors. You can think of them as morphine receptors, mu morphine receptors. And so basically we have different types, kappa, mu, and delta, but mu is the important one, and just shows you how this mu receptor located on the presynaptic part of the neuron here basically then facilitates neurotransmitter release, and this is the way it works in terms of the receptor and neurotransmission. And so this is a quick primer on the mesolimbic dopamine system, which is the key pathways and the key network in the brain that underlies addiction. And one of the key structures is the ventral tegmental area, which is rich in opioid receptors, also dopamine neuron cell bodies that project out to other key areas of the brain, such as the nucleus accumbens here, and prefrontal cortex, and hippocampus, and amygdala. And so again, that's probably a very key central part of the neurotransmission here. It's these opioid receptors in the VTA, which then impact dopamine neuron function and transmission and connectivity to other parts of this system. So mu opioid agonists, we already talked about activating mu receptors. The ventral tegmental area contains a dense concentration of those receptors, and so that is a big part of the addiction component here in terms of why opioids are so addictive. And don't forget, of course, what I mentioned earlier, that also tolerance and avoiding withdrawal is also a key part of that addiction process. So some important remaining questions. We still lack a complete picture of the acute and long-term effects of opiates in the brain and body. And more recently, there's been a lot of work on how opioids impact the immune system functioning in the brain. And I think you'll see that becomes more and more important in terms of understanding the effects of opiates in the brain. We don't, for example, also know how reversible or permanent changes are, those changes that are produced by long-term opioid use. I mean, we now have people who have been basically have had opioid use disorder for 10, 15 years. And then the question is, after all those years of long-term heavy use, clearly the brain changes, but can the brain change back? Is it reversible? We just don't know yet. It is important to note, I believe I mentioned it before, opioids can make chronic pain worse. So basically, there's the sensitization process that goes on, and there's certainly some data now that suggests that that long-term use of opioids is not helpful for chronic pain and actually can make it worse. So what are the most effective treatments, and how can we match treatments with patients who will be most likely to respond to them? The idea of, or the importance of trying to find treatments to help people get over their opioid use disorder, this is absolutely critical. It's definitely a priority for NIH, for National Institutes of Health, and for the National Institute on Drug Abuse, but we're not there yet. And we've been trying for a long time to figure this out. And we'll talk more on the next lecture in terms of what's currently out there in terms of treatments. But what you'll see is that certainly we are lacking in terms of effective treatments for opioid use disorder. So in summary, the pharmacology of opioids make them highly addictive. Social and environmental influences are important in terms of the initiation of misuse and abuse. And opioids target mu-opioid receptors in the brain, most importantly in the ventral tegmental area that activates the brain reward system. Repeated use causes long-term changes in these circuits, and repeated use also produces tolerance, and then cutting back or trying to quit results in withdrawal, which ends up being a very powerful incentive for not trying to cut back or quit. Okay, this lecture is going to be about what current treatments are out there for opioid use disorders. So here is the overview. We have several different types. One type is called medication-assisted therapies, or MAT. And here we're talking about pharmacological treatments. Two different types. One is opioid maintenance. So two medications are out there that basically help maintain people on opioids but with less risk. Those two medications are Buprenorphine and Methadone. And we also have Naltrexone, which is more for abstinence-oriented opioid rehabilitation. We also have psychosocial treatments, and those include things like contingency management, cognitive behavioral therapy, interviewing. And then we also have medical treatments for withdrawal, and so this is typically in the context of supervised detox. And then finally, some what we might call harm reduction approaches, and that is related more to the opioid maintenance. Okay, so pharmacological treatments. Let's talk about those first. There are 3 FDA-approved medications to treat opioid use disorder. Methadone. Methadone is a long-acting, we're talking a medication, an opioid here that works for 24 to 30 hours. So basically once a day, you take it once a day, and can be used as both in in terms of detox to help suppress withdrawal and cravings, but more often used as a maintenance medication to help reduce non-medical opioid use. Okay, buprenorphine is a partial opioid agonist that, like methadone, can be used during both detox and maintenance stages of treatment for opioid addiction. Naltrexone is different. This is instead of an agonist, it's an antagonist. It's a long-acting mu-opioid antagonist that works by binding to opioid receptors for 24 to 30 hours if you're taking the oral version, or for up to 30 days if you're doing the extended release injection called Vivitrol. So let's now sort of dig into the details a little bit more for each one of these. So for methadone, it's been around for a long time. It's only offered through approved and closely monitored clinics. And it requires pretty much daily patient participation. There are some dangers here. There's some risk. Overdose, there's a risk for overdose. If the dose is increased too quickly during the initial stages of treatment, there's also an increased risk of cardiac arrhythmias. To illustrate the risk here, there were 3,194 overdose deaths to methadone in 2017. So this is a non-trivial risk here. So usually there are three phases to the treatment with methadone. One is early stabilization on methadone, and then late stabilization, and then maintenance and eventually tapering off. Now, maintenance programs decrease mortality by approximately 50% among persons with opioid use disorder. So you may be thinking, oh, this is like crazy, 3,100 plus deaths. The thing is, even though there's a risk, ultimately it saves way more people than die in terms of the risks, right? So again, these programs decrease mortality by approximately 50%. So buprenorphine is another type of opioid maintenance medication, and it was developed in response to some of the drawbacks to methadone. So restriction of methadone to specialized clinics basically contributed to people wanting to develop a more suitable alternative oral long-acting opioid. So with buprenorphine, physicians can do office-based maintenance, and so they can prescribe buprenorphine themselves. They also are supposed to offer counseling or be able to refer patients for counseling, and they have to agree to participate in DEA inspections. But the important part here is they can do office-based therapy. Now, the negatives here, we still have the potential for overdoses, especially if it's taken along with depressant drugs, and there's also potential for illicit diversion. But there are fewer negatives than with methadone for sure. And then the pros here, mortality during the initial phase with buprenorphine is lower than methadone. So risks are lower, and that's a very important piece. That, along with being able to do it in physician offices, very important piece of why buprenorphine is out there. So I mentioned naltrexone also. Naltrexone is an antagonist that blocks mu-opioid receptors, and so it can help people maintain maintain abstinence from opioids because naltrexone is blocking those opioid receptors. The subjective effects of opioids are significantly reduced, if not completely eliminated. So again, because those receptors are blocked, if you're on naltrexone and you take an opioid, you're not going to feel it, at least not like you normally would for sure, because it's blocking those receptors. A very important point, though, individuals who are taking naltrexone have to be completely detoxified of all opioids before they take it, because if you take it while you're still on opioids, you're going to be thrown into immediate withdrawal, which will be extremely, extremely uncomfortable. So that's a big caveat. People have to be completely opioid-free and then start taking naltrexone. So another important piece of this is that they developed a more long-acting version. This is called Vivitrol. The injection is long-acting, and which is definitely helpful for some people. And then they have found this is most effective. Naltrexone is most effective when it's combined with some type of psychosocial treatment, like cognitive behavioral therapy, that basically targets the underlying addiction in a way that helps people. Okay, so let's talk now about psychosocial treatments for opioid use disorder. So I mentioned cognitive behavioral therapy. It's more short-term. It's focused on, essentially your beliefs and thoughts and feelings and the behaviors that are connected to those beliefs and thoughts and feelings. And we also have contingency management. And this is basically using positive reinforcement to change behavior. We have 12-step groups. Not a lot of research on 12-step groups, but a very popular choice among people. We have motivational interviewing, and this is basically a style of counseling or therapy where you are helping clients to explore and resolve ambivalence about their behavior change. And then finally, we also have family therapy out there for people, especially those for whom conflict among family members seems to be an important piece of their opioid use disorder. So with psychosocial treatments, there are pros and cons. Typically, they've been used to increase adherence during detox, which is important. And also, they've been helpful for treatment retention and during maintenance. One shortcoming is the ability to draw conclusions about these treatments because typically there's a great deal of heterogeneity, right? There's so many different psychosocial treatments out there. It's sometimes difficult to draw firm conclusions about the effectiveness of these treatments. So one obvious thing, of course, is what about combining medication management and psychosocial therapy? And there's one systematic review out there by Dugosh in 2016. And so basically, the most widely studied psychosocial interventions were examined in combination with medications for opioid addiction. In particular, they were looking at contingency management and cognitive behavioral therapy and focused on methadone. And the results of this work generally support the efficacy of combining those elements, right? So combining contingency management and cognitive behavioral therapy with methadone, generally the data suggests efficacy. However, there's also a lack of information about the use of specific medications in combination with other types of psychosocial interventions. So the bottom line here is complicated in terms of trying to figure out which combinations of psychosocial treatment and medications work the best. And obviously, this is an area where developing some best practice guidelines would be very helpful. So in terms of harm reduction, basically harm reduction is talking about different techniques to reduce the harm that's associated with drug abuse. And so risk reduction counseling is one such approach. And here it might be focused on preventing transmission of diseases like HIV, focus on needle safety and disposal, focus on overdose prevention, right? So I'm trying to get people information to reduce the harm and reduce the risks. And then methadone maintenance is also considered a harm reduction approach because while eventually the idea is that you'll help patients become abstinent in the meantime, and that meantime can last a long time, what you're really doing is giving them a safer opioid to use as opposed to what they get on the street. And so in that respect, you can think of it as a harm reduction approach. And then you might think, well, why aren't people just, using heroin in a harm reduction approach, right? Like medically supervised, for example. Heroin use, one study reported trying that, and basically the problem with that is there's still a whole host of risks involved, even if it's medically supervised. So, for example, respiratory depression and seizure. And so it makes that kind of a non-starter. Okay, so medical management of withdrawal symptoms. So this is early on, trying to basically give people a medication that will allow them to get through withdrawal. The advantages of this approach, of this treatment, is that it can improve patients' health and facilitate participation in rehabilitation. It may also help patients better consider abstinence because, obviously once you've gotten through the acute withdrawal, you're able to think much more clearly about the long-term future. Now, some of the cons that people have talked about with respect to medical management of withdrawal symptoms, that by itself, medically supervised withdrawal, is not sufficient to produce long-term recovery. So a lot of times people will come in or, make their way into these, into medical management of withdrawal, and as soon as they're done, they go back out and start using again, and that actually can increase the risk of overdose because people lose their tolerance during that medical supervision of withdrawal. And then obviously if your tolerance is lost and you go out and use the same amount of opioids, you're at high risk for overdose. So what about tapering programs? So this is, I think, very important. What happens when you have a person who's been on opioids for a long time and they want to quit and maybe they don't want to do any of the things we just talked about. So what's interesting is there are very few self-help programs out there. Almost everything is a program that involves physician monitoring. There are now several organizations that have put out guidelines for tapering. And by tapering we mean slowly cutting back on your opioids until you're done, right? Until it's basically zero. And so the VA system and the Department of Defense, their guidelines suggest a slightly slower tapering schedule for chronic opioid users. And so the dose reduction, the recommended dose reduction is 5 to 20% of the original dose every 4 weeks. They also suggest a faster tapering schedule for acute post-op opioid users. There, the decreases are recommended to be 20 to 50% of the initial dose down to a threshold dose. And that's followed by a decrease every 2 to 5 days. The Mayo Clinic for chronic opioid users recommends a decrease of 10% of the original dose every 5 to 7 days until 30% of the original dose is reached. That is then followed by a weekly decrease by 10% of the remaining dose. And the CDC recommends a decrease of 10% of the original dose per week. Some patients who have taken opioids for a long time might find even slower tapers easier. So the point here is that if 10% is too hard, because you've been taking opioids for so long, you can actually try less than 10%. So for the physician-monitored taper, what are physicians doing? Well, they're regularly monitoring your pulse and blood pressure and temperature. They may be taking urine or blood samples to basically check the type and levels of medication in your system. They may ask for your permission to speak with other healthcare providers or pharmacists or family members to get information that may help with the medication taper. And they may also be suggesting other pain therapies as needed to help deal with the chronic pain that you might be experiencing. And then also prescribing other types of medications to help manage withdrawal signs or symptoms, things like sleep and appetite and negative moods. So those are the things that are going on during a physician-monitored tapering. Here are some tips to basically minimize withdrawal during a taper. Staying hydrated, drinking plenty of water, eating regularly and eating healthy, staying active with moderate exercise. That might include walking and stretching. It might include some deep breathing exercises, relaxation and meditation techniques can be important. So, breathing exercises, meditation, guided imagery, keeping a positive outlook, and surrounding yourself with people who are also positive, and then importantly, not substituting alcohol for the medication you're tapering down. Those are all, I think, useful tips in terms of minimizing the discomfort and withdrawal that goes along with tapering. So, what about acute opioid overdose? What do you do? How do people intervene during an acute opioid overdose? So naloxone is an opioid antagonist medication that's designed to rapidly reverse an opioid overdose. And there are 3 FDA-approved formulations of naloxone. One is an injectable formulation that basically requires a professional to administer it. One is an auto-injectable formulation where families or emergency personnel can quickly inject it into the outer thigh. Once activated, that device provides verbal instruction to the user describing how to deliver the medication. It's somewhat similar to an automated defibrillator. And then finally, there's a prepackaged nasal spray version of this called Narcan. It's pre-filled, it's needle-free, it requires no assembly, it's sprayed into one nostril while the patient is lying on their back, and that also can deliver a life-saving dose of naloxone. Okay, in summary, there are a number of different psychosocial approaches like cognitive behavioral therapy. We also have a number of medication-assisted treatments that are more maintenance-based like buprenorphine and methadone. We have tapering programs, which generally call for a 10% dose reduction each week in your opioids. And we have treatments for acute overdose that involve quick administration of some form of naloxone.